So 23rd of March 2020, I don't think that date's going to escape anyone's mind anytime soon. That was the day that we went into lockdown and our lives were just turned upside down. The lockdown really exposed a lot of significant structural inequalities, particularly for our ethnically diverse communities. And the ONS report that I'm sure most of you will be aware of and will have read in July 2020 really highlighted some of the disparity between our Black and Asian ethnic minority population and our white population. So I won't read through the slides, but you can see there just how adversely impacted people were. These health inequalities, we know they've been around for many, many years before COVID. COVID just shone a light on it, but it really pushed Sussex as one of the first systems, so partners, to really start to look at what we could do to support our ethnically diverse communities, recognising that actually a lot of the issues were around employment and other socio-economic factors. There was also a lot of challenges with accessible information, a lot of confusion and a lot of fear, and I think that was across the whole population, but to have the additional barriers with information not being provided in community languages, I think that just heightens the anxiety and the fear. So how the system has responded to inequalities. I think it's first very helpful just to explain what the system is, just in case anyone doesn't know. So in Sussex, we have something called an integrated care system with 24 different partners, and we're really trying to come together with local authority and different providers to work collaboratively, to not duplicate, but to also have a better impact and a further reach into our communities. So the first thing we did was we have a really good working relationship with our local interpreting services. We spoke to them and we relaxed the contracts that currently were only allowing for face-to-face interpreting, recognising that we needed to offer telephone interpretation to these organisations as well. We also set up something called the BAME Disparity Programme. I realise BAME is not a word that people can associate themselves with or identify with. It was an NHS England programme of work. So we have tried to move as much as we can away from the word BAME, but I just wanted to highlight that. As part of that programme, which started in May, we commissioned some organisations to go out into the local communities and understand what the fears were, how people were being impacted, not just with health, but all those other socio-economic examples as well. And there's some really strong reports that can be viewed on the webpage, so I'm sure the slides will be able to be shared afterwards so you can view them. From these engagement pieces, we kept hearing, so what now? You know, we told you this, we know what the issues are, we told you what they are. So we've created an action plan. It was collaboratively put together with the local authority, with partners, with interpreting services, so that we could actually try and make some short-term impacts, but also that longer-term structural inequality, tackling those issues as well. And also DRI have supported and taken on 4 webinars focusing on health, mental health, job opportunities and education, and the final webinar is in February, so I would definitely suggest that you attend that if you can. The last thing we did as well was a locally commissioned services, and this is something that we do in primary care. So the first thing we did was we sent out letters to our ethnically diverse population in over 40 different community languages. I think it did show us, again, some issues and some barriers, especially with collecting diversity data. So a lot of our GP practices didn't actually have information about race, religion, etc. And so it's something that we're really now focusing in on. And it's purely so that we can then make sure that the care that we deliver is appropriate for the person and that they have as little barriers to healthcare as possible. So as well as that letter, which was really just trying to put people's mind at rest. It gave national guidance on how to protect yourself from COVID. It talked about taking vitamin D, just to make sure that people were receiving information that was factually correct, because we were very aware that, especially on social media, there's a lot of misinformation, and people were just getting very confused. The other thing that we've done is recognising that our ethnically diverse communities are heavily impacted by COVID. If a patient does get COVID, they will be sent something called a pulse oximetry meter, and it essentially it monitors the amount of oxygen that's in your blood. And if it's too high or too low, you can then be transported to hospital if you were deteriorating. So that's now in place, and if anyone does have COVID, they can contact their GP practice and that will be sent out. The last thing to mention about the locally commissioned services, we did put on a webinar for linguists and social prescribing workforce to talk about how they might be asked to get involved, and I can share the slides from that presentation as well, so in case you are asked to support, particularly with the pulse oximetry service.